What about management? For all of us who are in the field of preeclampsia, we really understand that treatment of preeclampsia is balanced between pregnancy termination to prevent maternal complications and pregnancy continuation to prevent fetal immaturity. In other words, at some point during the management of preeclampsia, you may come to a tough decision to induce delivery or to do C-section in a woman to prevent her complications, but at the same time, it may be too early in pregnancy and baby may not benefit from that intervention because of possible prematurity and related complications. Therefore, that decision really needs to be made between obstetricians and internal medicine specialists, and blood pressure management under those circumstances is particularly important, and we will talk about it more later. The gold standard for treatment of preeclampsia is delivery, and it's usually performed for mild preeclampsia at 37 gestational weeks. For severe preeclampsia, it's usually 34 gestational weeks. Expectant management is advisable only in tertiary facilities, particularly for these severe forms when a woman is at high risk for neurological complications and we are dealing with immature baby. Magnesium is given for seizure prophylaxis and corticosteroids for lung maturation. When we are talking about treatment of hypertension in pregnancy in general, the approach is typically totally different from those approaches that we are using in non-pregnant patients. Why is that so? It's predominantly due to assumption that hypertension in a young woman, premenopausal woman who does not have any other cardiovascular risk factor, does not increase or lack of treatment does not increase her overall risk for cardiovascular disease. That assumption is challenged by some hypertension trials in which indeed trials are showing that even a short duration of hypertension treatment may indeed decrease the risk for cardiovascular disease later on. The other concern for women who are pregnant, who require treatment for hypertension, is that decrease in blood pressure in mother can compromise fetal placental unit. Therefore, that treatment of hypertension again needs to be done, balancing risks for baby and benefits for mother. What are we basing these treatment strategies upon? There are really not that many well-controlled, well-designed studies based on which to draw. And I will briefly discuss with you current treatment strategies and the most recent data. American College of Obstetrics and Gynecology is suggesting treatment of hypertension in preeclampsia for systolic blood pressure greater than 160, diastolic greater than 110, and for chronic hypertension for the similar blood pressure cutoffs, and aiming for systolic blood pressure in chronic hypertension between 120 to 160, and for diastolic blood pressure between 80 and 105. As you can see, these guidelines are not really helpful for practicing physicians, because they really give a wide range of blood pressure: systolic 120 to 160, diastolic blood pressure 80 to 105. And I can tell you that my personal approach when treating women with chronic hypertension is aiming for blood pressure lower than 150 over 100. And for women with pre-existing renal disease, I try to keep diastolic blood pressure in the range of 90. One paper that was published 2 years ago I find it extremely helpful when justifying treatment of women with hypertension in pregnancy. That paper compared less tight versus tight control of hypertension in pregnant women. Trial compared less tight control of hypertension with targeted diastolic blood pressure of 100 versus tight control targeted diastolic blood pressure of 85 millimeters mercury. And they compared pregnancy outcomes such as loss, high-level neonatal care, serious maternal complications, and severe maternal hypertension. They include women both with chronic or gestational hypertension, but they excluded those with proteinuria. So this is a description of the trial, and you can see that they were successful in recruiting approximately 500 women in both groups, and these women were pretty much similar to each other. I just want to bring to your attention the fact that approximately 75% of these women had pre-existing chronic hypertension, and approximately 25% of them had gestational hypertension. From randomization until delivery, blood pressure was higher among women in less tight versus tight control group, which basically tells you that investigators were able to achieve blood pressure control that they aimed for. And these are the outcomes that they actually were able to assess, and that they aimed to compare between the groups. As you can see, with respect to pregnancy loss and high-level neonatal care, there was not a significant difference between these two groups. When they look into secondary and other outcomes, you can see that one outcome that was different between the groups was risk of progressing to severe hypertension, which was significantly lower in women with tight control hypertension. There are some trends towards differences in some of the clinical findings of HELP syndrome, although HELP syndrome per se was not different between the groups. So this is the figure that I would really like to discuss with you, because this is really the most important finding of the study. Again, women with less tight control presented in orange compared to those with tight control. For each cutoff of blood pressure, they were at higher risk of having high blood pressure, both systolic and diastolic. The medication that they used were labetalol, metidopa, and nifedipine, and I'll talk to you a little bit more about medications that can be safely used in pregnancy. So, results of this study, which is really setting the stage for the way that we are going to approach these patients in our daily practice, is that there was no difference in the primary outcomes. There was also no difference in serious and other maternal complications. However, severe hypertension was more common in less tight control group. There was also no difference between chronic and gestational hypertension. With respect to fetal outcome, there was no significant difference in perinatal mortality. Intrauterine growth restriction was not significantly lower in less tight control group. So overall conclusions: tight control of hypertension in pregnancy confers no apparent benefit to the fetus, but also does not pose a risk to fetus or newborn. However, tight control shows moderate benefit in preventing progression to severe hypertension for the mother. Why is that important? If you remember, when we were discussing indications for either by induction or by C-section, severe hypertension was one of the indications to pursue with the delivery and pregnancy termination. Therefore, by treating the hypertension and preventing progression to severe hypertension, indeed, you may prolong pregnancy, which may be quite beneficial for fetus, and also preventing severe hypertension in mother can prevent maternal complications. Interestingly enough, these results were consistent with results of Cochrane review in 2014, that meta-analysis included 49 trials with close to 5,000 patients and had a similar conclusion. In other words, treatment reduced the risk by half of developing severe hypertension, but had little effect on the incidence of preeclampsia. Now, what are the medications that are relatively safe for pregnancy? Typically, for oral treatment, for PO treatment, we are using metidopa. For IV treatment, we use hydralazine, and labetalol can be used both in its oral and IV form. Medications that are absolutely contraindicated are ACE inhibitors, angiotensin II receptor blockers, because they cause fetal abnormalities. Another medication that needs to be avoided in pregnancy is spironolactone, because it has anti-androgen effect and can cause ambiguous genitalia in male fetuses. Another medication which is here listed that should be avoided in pregnancy is atenolol. It has been associated with intrauterine growth restriction. It seems to be the effect of atenolol only, and this does not apply to other beta blockers. Non-pharmacological therapies. I think when I was training in OB, there were things that we really strongly encouraged, such as strict bed rest. Now, strict bed rest is not recommended. Weight loss and extremely low sodium diets are also not recommended. For women with well-controlled blood pressure who have a history of chronic hypertension, they can continue with moderate exercise. One thing that came with these new guidelines is postpartum preeclampsia. And I cannot stress enough how important this condition is. There is an overall dogma that once a woman delivers, because she delivered placenta, she is not at risk for postpartum preeclampsia. That is not the case. Indeed, certain percentage of women can develop postpartum preeclampsia, which basically means that upon discharge after delivery, all women, irrespective of their pregnancy course and delivery data, they should be advised about possible signs and symptoms of preeclampsia, and they should be told if any of these occur that they need to present themselves into the emergency room. New onset hypertension postpartum with neurological symptoms needs to be treated the same way as if that woman were pregnant, meaning blood pressure control and magnesium prophylaxis. What about prevention? With preeclampsia, since we have only one way to treat them, which is delivery, a lot of effort actually has been put towards preeclampsia prevention. Unfortunately, none of these strategies seems to work very well. Antioxidants, vitamin C and vitamin E, are not effective. Initial studies were promising, but well-designed study did not show any benefit. Calcium may be useful in populations with low calcium intake. Bed rest and low sodium diet do not prevent preeclampsia. The only potentially strategy that may work is low-dose aspirin started prior to 14 weeks. There was a large meta-analysis that included more than 30,000 women that showed 10% reduction in the relative risk of women for preeclampsia and early forms of preeclampsia. So low-dose aspirin is indeed recommended for early onset preeclampsia and preterm delivery. For those women with recurrent preeclampsia, and is typically given in the dose not greater than 100 milligrams daily. Future directions. One of the things that really remains to be resolved and solved is the issue with women with chronic hypertension in pregnancy. Does early and tight control of blood pressure may indeed prevent preeclampsia? We don't know that. Current data are not allowing us to come to a definitive conclusion. And most of the experts in the field will tell you that's not the case. But, you know, solid data from well-designed studies are missing. There's also a question, is there any subgroup of women with chronic hypertension that may derive benefit from diet control? For example, nowadays, we are seeing trends towards first pregnancy occurring later in life. These women are not your typical women that you are thinking of when you're talking about first pregnancy. Indeed, you can see a primipara in her late 30s with a history of hypertension, with a history of polycystic ovary syndrome, somebody with metabolic abnormalities. And the question is that that woman may indeed benefit from blood pressure control. This is not your 20-year-old woman without any risk factors for cardiovascular disease. So the question is whether or not these women may derive benefit from blood pressure control due to their elevated cardiovascular risk. The other topic that I would like to discuss is the fact that hypertension in pregnancy is associated with future cardiovascular disease. So the question is whether the treatment of hypertension in pregnancy may lower their risk for the future cardiovascular disease. And they really don't have answers to these questions, which I think are crucially important when we are taking care of women who have hypertension in pregnancy.